I'm Carol Robinson. My consulting firm, Cedar Bridge Group, has contract with MiHIN to help on a few things, and we're going to tell you a little bit about the electronic consent management system that we're working on. I'm going to let Kathleen Connor introduce herself real quick, and then we'll go start into the presentation.
Thanks, Carol. I just want to give a little background in terms of my experience in this area. I've been working on privacy policies and consent since 1993, and I've worked with Joy Pritz on a number of papers, and she was the National Privacy Officer just preceding Lucia Savage. I'm now working with the VA on privacy, in particular privacy on FHIR at HL7. I worked with SAMHSA previously to do this data segmentation for privacy and early consent directives in HL7. And I will continue, I guess, working on some of these projects with Carol on behalf of MiHIN and their efforts to have an electronic consent management system that is very interesting nationally because it's a super consent directive management system that's going to unify all of the consent directives at the local HIEs. So with that, you want to give that background?
Yeah.
Thank you.
Great. Let's make sure I have this go this way. Sure. So this is a really great time in standards development because we're moving from a very restrictive kind of environment where in most behavioral health environments there are limitations to sharing data, and some of those are very much constrained by the technology, and some of them are constrained by policies that differ from state to state and are, of course, subject to federal law, CFR Part 2, 42 Part 2. But I think the thing about this time that we're experiencing and the work on more granular consent options that we'll describe to you today is that the culture of sharing behavioral health data will also be changing. As patients are given more granular options for sharing their data, with whom, when, and for what purpose, that I think the providers that provide services, whether behavioral health or physical health services, and I always say to people, my brain is part of my body, so sometimes I'm not even comfortable with the way that we bifurcate healthcare in that way, and it does lead to those cultural kinds of issues in data sharing. And so this is a very exciting time, and we really want to talk about what Michigan Health Information Network and Michigan as a state has been doing in thinking about how to advance this from an electronic consent management system, and also in thinking about how when standards are ready and developed and rolling out in vendors, how the opportunities for providers to communicate with their patients about who they share data with, how, for what purposes, and what the value is for that, because that's really what it gets down to is how to take care of us, all of our needs, our brain needs and our body needs, but also how to ensure that care is better coordinated between multiple providers, and how care also, the provision of care is managed and measured for value-based payment. So it all kind of ties together. The use case principles of the Michigan Electronic Consent Management System, and we'll use ECMS as that acronym from here on out, are really around three things that I have really gleaned out of all the documentation, then all the work that's been done and all the meetings that have gone into this point. And that's really around the principle that patients should be able to determine when and with whom their sensitive data is shared. Behavioral health providers should be able to participate fully in exchange, in health information exchange, and efficiently. It shouldn't be, overly burdensome for behavioral health providers to be able to track the consent of their patients to share the data and participate in HIE activities, whatever those, whether point-to-point or whether query-based. And finally, that the regional HIEs here in Michigan should be able to also efficiently manage patient consent determinations, and that they should understand those determinations when patients are seen outside of one region and perhaps in a different region, and that those consents are then in different places. So there's two necessary components. One is the standard statewide behavioral health consent form that's been developed here in Michigan, and Kathleen has the paper form for that.
Can we ask how many people in the room were involved in developing this form or involved in developing the consent management system specs? It would be nice to know. I hear that there would be
a few hands. That's great. Thank you. Thank you for doing that. And then the second is that you need this ECMS system to be able to manage that, because managing a paper form, as we'll show you, it becomes incredibly difficult, as you know from your own work. So here we are in the current state, and you can see the hospital collecting a HIPAA permissions that we all are asked to update every year. And then over here on the behavioral health side, on the right-hand side of that slide, that if there's pre-existing behavioral health information in your record, that you also need to use this form. And of course, you see that red X in terms of that going and being managed at the HIE and the level, so that in this current state, each and every place where you might present for care has to manage this care. So we're going to give you a little scenario of this.
Right. And it's based on the work that's already been done for the use case for the state, which I think is fabulous, where Carol will be the patient, and she's a behavioral health patient.
Which some people would understand could have possibly been true at some point.
No. And I'm the admit clerk. Okay, and so we're going to do, we're going to do two scenarios of the as-is. And in the as-is, which we're looking at, the first part, I say, welcome to the hospital. I'm the admit person, and I see that your PCP and your behavioral health providers have faxed your recent records, and they faxed a consent form for you that you've already signed. Is this the signed one? Yes?
Yes,
Confirm
that's
it?
my signature.
Okay, and so you're going to opt out. And what I need to know is this information, so I can enter it into, key it into our EHR admit system. And so you're saying that we're going to opt out of sharing of all your behavioral health information to anyone but your behavioral health providers, and that you only want your sister to be able to know that you're in the hospital at this time.
Only my sister.
Okay, thank you. Now, what's going to happen next is the admin clerk has to take this paper after keying it in manually, and it's going to have to go file it in some file. And then if somebody wants to call and find out if they can get access to Carol's records, even the behavioral health provider, they're going to have to go pull this and answer it by phone or by fax. So that's as in one. Now, in as in two, this hospital now is able to communicate and receive Carol's records through the HIE, but they still are receiving this form through the fax. And again, Carol, is this the one you agreed to?
That is the one.
Okay, so in this one, I'm going to still have to ask you whether you are opting out and whether your sister is the only person that knows you're in the hospital at this time, so I can enter it into the system. Yes?
Yes, that's right.
Yeah.
But I'd really like to revoke my sister's privileges at this point.
Oh, okay.
I don't want her
Okay.
to know what's going on. I don't want her to know. I'm mad at her anyway, right?
Okay, so I'm going to go back into the ADT system, and I'm going to change information about who you're allowing to visit you in the hospital and know that you're here. Thank you, Carol. Okay, so we're going to move to the new future, the 2B.
So here in the proposed ECMS future, that there's a variety of participants here. Of course, you see my PCP as a patient. You see the hospital that I have had reason to present at. And you see my behavioral health provider. But in this scenario now, the management of this form works very differently, and Kathleen will show you that.
Right, so at this point, we're going to electrify this. This is no longer a paper form. So when Carol comes in, I go, oh, I see that the information that we need to understand your sharing preferences have already arrived from the HIE, and we want to make sure that here's the tablet. We'll pretend this is a tablet. Do you agree? Yeah.
I do agree.
Okay. Did you want to revoke your sister's thing, though? You could actually update this.
I do want, no,
Okay. good.
yes, well, yes, I want to revoke it.
Okay. 'cause
Wait, no, yes, yes, I do.
Okay, okay, so you saw the one that we had previously, and now you're deciding that you want to revoke it. Okay, so now it's all electronic, it goes directly into the EHR, and the EHR is going to send this information to the local HIE, and the consent will go to the local electronic consent management system, and what it's going to do is it's going to take an electronic subset of this, which will only be the important metadata that needs to be known in the registry. It'll say where the electronic version of this is at the local CMS, and it will provide anybody in the state information about whether Carol is currently has an active consent directive and whether or not she's revoked access to anyone else. The alternative is that every time one wanted to check whether Carol had revoked a consent directive, they'd either phone or fax or have to electronically correspond and bidirectional queries to the other other six local ECMS. So this seems to be a very value-added approach to making it more efficient, letting Carol express her consents as she wishes, and to also allow her to access her consents, all of her consents in an electronic form anytime she wants, and hopefully in this new world, given patient right of access and the new MIPS rules, she would also be able to ask the HIE to send her consents to the endpoints of her wish.
Right. So if I decide that my PCP, Dr. Meany, doesn't really need to know that I've presented at the hospital, then I have that choice. But it also, the desired future state also gives the providers, those relationships, an opportunity to talk to their patients differently about sharing the sensitive data and being able to talk to them about why it's important. With the paper management of consent forms that we hope becomes a thing of the past very soon, that opportunity to discuss it was really limited because most providers don't really believe that this system is going to work effectively. And so the culture then is to take the information and basically lock it in the file cabinet, whether that's in the EHR system or whether in a lot of cases it's an actual file cabinet. And
or
so
segmented in an HIE.
right, exactly. So in this case, I think that not only does the patient have more choice, but those cultural barriers to data sharing will begin to break down.
Right.
So
Right,
Kathleen's
and
going to,
I just wanted to
oh,
add
sure.
just one more component of what you had said earlier about the body-mind kind of, or behavioral, physical information being more readily available. what this does is, by not sequestering the entire record, because they're afraid that it has information that might be covered under one of these laws, for which there are fines, and it's not only 42 CFR Part 2, it's also all the veterans have a similar right under Title 38, and every state has their different privacy laws. So people are afraid that if there's any indication in that data, even whether it's structured or unstructured, they're sequestering the entire body of information and not sharing it. By going in this direction, they are now going to be able to sequester only the pieces of information that she specifically asked to be opted out for, and even she can possibly opt in for some of the sensitive information as well. So the data flow that's needed for the kinds of future that Dr. DeSalvo articulated would now be enabled.
That's right. But why don't you go ahead and give us the technical overview, and I'm going to step off the stage and let you walk through the technical side. Well, I'll sit down over here. Okay.
Okay. So I just want to give a quick background. In the scenario that we were playing out, when I handed Carol the tablet, what she saw, it might look like this, but what she saw is kind of what Linnell was talking about, the interest in the payers having use of the structured data capture questionnaire, enabling folks to see something that they can relate to in a patient-friendly form. They can fill it out on the tablet, they can electronically sign it, but that FHIR-enabled view would be used to populate a FHIR version of the consents that have been used previously, the actual consent directive record. In V2, we have the consent segment, which is the one that the ECMS is actually looking at of implementing first. It could do it with the CCDA or the consent to share version of the CDA that is being used in a lot of behavioral health enabled HIEs, or they can actually populate a FHIR version of such a record. So I just wanted to point out that the scenario we were talking about actually are some of the pieces of the technical overview that I'm going to go through. And the other thing I want to talk about is the relationship of these. Hey, which way do we push?
It's the green button.
Yeah, the one that says arrow. Okay. I wanted to talk about some of the other drivers for this effort. One of them is the current Office of the National Coordinator's Patient Choice technical project. And what they are doing is looking at finding the best standard or standards that would enable this vision that we just articulated. And one of the important things to take away on that is there's always a separation between the most, I guess I'll put it this way. In the consent architecture, you have many layers of protections to ensure that this very private information is only accessed by the authorized, clearly authorized person. So they know whether or not Carol has opted in or opted out of behavioral health. So that's why this piece is separated so that authorized persons to get the index can only get this much, and they can find out whether or not this is available or whether or not they even need to have it, because if the response from the MiHIN ECMS is that this particular consent has not been revoked, then there is no need to go look for this or no need to approach Carol again and say, hey, you want to come see me, but you revoked the consent. I need it again. So that's some of the advantages that we want to point out. Okay, so the other thing is that there's a long history of standards that support this, and they support the separation of concerns between the content, which would be this part, and the management, which would be the control of the metadata that allows folks to see in their workflow whether the consent is current or revoked or has expired. This one, I think, is only good for 1 year, so that's going to be a concern in the state of Michigan. So that separation of concern has been ubiquitous throughout the consent standards that we've had. Beginning in the 1990s, HL7 developed the consent segment, which kind of records, would be the electronic recording of what she'd actually signed on paper. But the metadata is carried in the ADT feed in a segment called the access restriction values. And in that segment, you're able to put the metadata that you need in order to manage it in your environment. So the next part is the CCDA. Again, CCDA consent, the CDA consent directive, what it actually does is carry the body. Thank you. I think I'll take advantage of that. It carries the body, this most sensitive piece, but the overarching protocol for actually registering this at an HIE, which is based on the IHE XDS metadata. I think you all are familiar with it if you do any part of the exchange protocol. That registry information is limited to the metadata out of this. So it's happening both in the IHE, basic patient privacy consent. It's happening when it's being used to query or find a consent directive CDA. And we hope to go forward and have the same thing in the architecture for FHIR consent that we're working on right now at HL7. The other part is there's a very tight relationship with the data segmentation for privacy. I don't know if people are familiar with that. Anyone heard about that? It's now one of the options for meaningful use. And what it does is it says that you can mark sections, the entire document, or sections of a document with things called security labels. And what security labels are very similar to what in Michigan are called privacy tags. And what these are is a set of HL7 normative vocabulary that allow you to say, this piece of information can only be accessed by this requester if they happen to have in their provisioning of authorization, their role, their other access, attribute-based access control clearance capabilities, such that they can see HIV, they can see restricted information, or they're a care team member. If the requester's security labels in their clearance meet or exceed what's on those pieces of information, then they can have it. But guess where those security labels are coming from? They're coming right out of this. So when you look at a FHIR consent directive, if you look at an HL7 consent CDA, you're going to find that those codes are there. And that's how systems are able to populate both what's on the resource and what the provisions on the role are. That covers that one. Now, what I want to point out is in the process of developing the data segmentation for privacy standards, the ONC also found that there were these separations of concern, and here's their stack. So you'll see that there's a layer that is the actual, I'm going to go to, the first one is the security label or content tagging. Then you have the structure, the actual consent record. Then you have the metadata, which can be used to, they call it manifest metadata. That's that indexing information that goes to any kind of registry. And you have the user context, so you make sure that you have an authorized requester, and then you have capabilities for doing the request, either pushing the consent directive or pushing the information or pulling the consent directive or information. And then, of course, we have foundational security. So all those pieces need to be replicated when we move to FHIR. And most of those pieces are already there, and all we have to do is finish the FHIR consent architecture piece. We have some of the components. One piece has been in the first and second DSTU, and will probably be in the third STU now coming up. And the question is how we're going to deal with this idea of a consent tracker, is what I kind of call it, is the approach to managing that metadata. And I'm looking to Wayne and hoping he helps us out with that one. He's the CTO. But I will say that in the process of making it this far, like 4 years into FHIR, it's suddenly become the sexiest topic in the universe. I never thought everybody would be so interested in consent, but they are if you look at the listserv. Okay, so next, I want to tell you a little bit about what the Office of the National Coordinator, National Privacy Officer, Lucia Savage, is doing in meeting the vision that was articulated by Dr. Tasava when she was talking about we have data blocking issues happening. Not, she wasn't focusing on vendor or provider or any kind of payer, any kind of malicious blocking, but a lot of it they consider possibly due to misunderstanding about what HIPAA allows. So the first part of their agenda, and she talked about it yesterday and the day before, working closely with OCR to make sure everyone knows the rules of the road and what is allowed to be shared. And so when you look at, this is their icon, the permitted rules are the HIPAA rules at the bottom. And then there's this idea that states have and other organizations have a right to set a higher bar. And they can say, we want to make sure that our patients are opting in or opting out of the collection and sharing of their data. And then there's a third level where you get to granular choice, which are required under those federal laws and state laws we talked about earlier that allow a patient to segment their data and keep certain parts of it private if they wish. So those 3 layers are being addressed in the process of the technical project that I work on. And right now, they're very interested in finding one standard that they can use for all those levels. So FHIR comes to mind. And then the other thing I wanted to say about this is, one of the things that was nice about finding out about the Michigan ECMS plans was that it actually mirrors the work that has been developed in the use case for the Patient Choice Project. Now this is tiny, but if you have a chance to get these slides, what you'll see is in the push scenario is very much what's in the game plan for the ECMS, where the local, the HIE or the provider can push the consent directive to their local ECMS, and that ECMS can push the metadata up to the higher level statewide ECMS. And that's right in your specs, and it's right in the patient choice use cases. The other one, did I miss one? Yeah, okay. Then go back. Oh, the second one, this is a pull use case. And this is also in your spec. And again, in this scenario, the provider is asking the MiHIN HIE whether they could get access to information. And in the flow, the MiHIN ECMS can go out and locate and find where a consent directive might be, or it can look at the metadata that it has, and it can report back to the HIE whether or not that requester can have the information. So you're right in line with exactly what the Office of the National Coordinator is doing. So here are some of the patient choice data set considerations. One of the things I've been doing is mapping across all the standards, both for the piece about the indexing and the querying and the piece about the actual content. And we're bringing some of those requirements into the set of requirements we're asking for FHIR to adopt. And I'll take a real quick look at it, but there's 2 pieces. Again, separation of concern, there's the profile, and then there's the tracker or the metadata management. And I wanted to show here, this is an illustration of the MiHIN architecture, this ECMS, and you'll see that it very closely tracks to what we're doing at the Patient Choice Project, which that's why I called you guys when I saw the presentation. I think it was Direct Trust put it on. I said, you guys are doing exactly what we're doing. And that was the first chance I had to talk to them about it. Okay, so I'm just going to do a really quick overview here. It's the materials in the slides, the material you can find out on the HL7 wiki for FHIR. But in general, there's a proposal for a consent tracker resource, and it would basically be the FHIR-tized version of what V2 does with V3 and the use of the consent CDA, CDA consent, which is the same thing as consent to share, and what we're hoping that FHIR can do. So these all provide the ability to help manage workflow related to consent directives, make sure that, you know, if I have a patient coming in from a referral, did that patient consent for me to get her records? So you can go check. It provides a method for the consumer information to be stored, managed, queried, or deleted when it's expired. And the metadata typically includes all the provenance you need. It includes the security labels you need to know whether you even have to go get the consent. You can say, this person's security labels match the requirements that are here in this metadata, so they can have it, because we know the consent has not been revoked yet. You don't even have to pull it. And it allows you to decide, you know, in situations where there are different domains and authorities controlling the enforcement of the consent directive, which domain will trump. So there's been discussions about possibly having the Michigan ECMS be able to talk to another state super ECMS. And when that happens, they're going to have to decide what the rules of the road are. So for example, in the DRSA, for the N1 or e-health exchange, there is a rule that the receiver's rules trump. So even if you had higher requirements on the sender side, it's the receiver's side that's going to decide what's actually enforced. That could be changed. That'll be something that will be worked out as the states start sharing consents across the borders. Okay, and I'm going to skip forward. I'm going to skip these are examples of elements and definitions that I've been proposing for the FHIR consent architecture. And in the FHIR consent directive profile, just to be brief, there's the same components that you're going to see. It can replicate this form. Exactly. You would be able to have a profile on it that had only these pieces of information on it. But another state would be able to use it to create a profile that reflected their particular form. The VA is actually one of the patient choice pilots, and they are going to be replicating the VA's disclosure form using this approach. And again, the rest of the presentation, I'm going to just stop here because it's basically the elements that map to all of these other consent directive contents, and go back to Carol and see if she wants to help wrap this up.
Thanks, Kathleen. I think the details on the slides were put in there just to help capture, you know, what do you really mean? What's under the covers when you talk about this? And Jeff, I assume these will be available for participants if you really want to dig down and look at the segments here, because I think as we click through, you can see there's a variety of profiles here that are being developed under the FHIR HL7 consent directive work groups. So, and as Kathleen alluded to, this is still in development by HL7. There was a Connectathon in Montreal last month where there was a lot of discussion around aspects of these profiles, and I click through and you can see, you know, numbers of, you know, key decision points that will have to be made. But when you get down to essentially the mythbusters, that In fact, the upside of any consent is that any type of consent directive can be represented. So this can be done for medical purposes or treatment purposes. It can be done for research purposes, which is very important. And you heard some discussion yesterday, or I'm sure recently. I was thinking with the HIMSS meeting that I attended yesterday, there was some concerns around the shared IRB ability to share data between different approved IRB research projects out of IOM, Institute of Medicine. This profile, the FHIR consent management, could easily help manage that as well. And then advanced directives and advanced directive registries, or in a lot of states they call, there's two terms. One is POLST, which stands for Physician Orders for End-of-Life Treatment Services, and the other would be medical orders for end-of-life treatments. And so advanced directives, POLST, and MOLST forms are going to be managed more and more in an electronic world. And in Oregon, in fact, in 2009 legislature, that was the first statewide electronic system to collect what we call POLST forms. And those are typically for very, very elderly or disabled or people who are very close to the end of life, whereas an advanced directive could be very, very, very healthy person. But these registries are going to be more and more important. And the reason why is very simple. It's about honoring patient choice. And so being able to use an electronic means so that whether it's an emergency medical personnel that arrives at a nursing home or in a park when somebody collapses, that they know that this person wants to have every treatment provided to them.
I'm loving this, because in this you can imagine just the same scenario we used where the EMT's got the tablet and they're downloading the metadata straight out of these registries using FHIR, and they can confirm if the patient is actually conscious, whether they want to go with this. And yes, I love the picture you're painting.
That's right. And so I think that in talking about this from a very real, on the ground kind of application, that while we have the behavioral health form here, that you can see that there's multiple applications for this ability for consent, and that the value in honoring patient choice across our lifetimes and the type of care that we receive will be really tremendously enabled by this. So basically, this is where we're at in terms of HL7's work, I think, and you can use this link to keep up with that, right, Kathleen?
Yes, and also we're getting some of this into the bill now, so the links that Linnell shared will also be, you can go straight to the FHIR site. So I want to say that. I also wanted to say that in the proposed version that we're putting out, there's a value set. It's called consent directive type, and in it, there's a code, and that code is the DCH 3927 from the state of Michigan, with a link to the actual form. It is in the proposed value set for the FHIR consent directive. So I want to tell you how much I appreciate being able to get to know your state and to be able to understand the use case, and working with Carol to understand how this applies to other aspects of patient choices has been invaluable. So we have 4 minutes if there are some questions. Okay, sure. You go ahead on the question.
Your patient changed her mind 4 times while you were talking to her about whether she was including or excluding her sister. So for timing issues and for authentication issues, if you don't have a signature captured, how do you authenticate that the decision on record is the most recent decision and that it was indeed a decision authenticated by the patient? Are there biometrics, thumbprints, date timestamps? How?
This is going to be part of the architecture that will, FHIR requires, in any of the HL7 ones, assume that there are the privacy and security infrastructure in place. It will depend on the architecture and the implementation and their policies as to what they're going to do. So in a discussion last night, it was, even in the state of Minnesota, you have to have a wet signature. They won't accept an electronic signature. The VA, on the other hand, will accept an electronic signature, and they allow the patients to be proofed and receive that when they go in to see their doctor. So there are lots of ways to do this. OAuth offers a lot of flexibility on how to handle it. In FHIR, there's an actual data type for signature that allows the signature to be a wet signature. It could be electronic signature. It can be a digital signature. And another approach that's used in some places is that the provider or whoever obtained the consent will sign, or the patient will sign maybe in paper or even electronically, and then they will sign over it to give the provenance and integrity that is required for a lot of people to know whether that's the one that should be taken. But in this new architecture, it will be much easier to find out whether Carol has revoked consent or not, instead of having to poll around and see whether she revoked it one place and the provider over here, who she's revoked on, doesn't know. This architecture will solve that.
Yeah, and I think that to that point, and that's exactly why I role-played that, is because that lack of confidence in terms of, well, I'm not really sure what she wants, but the end decision was made, yes, I'm going to revoke that. I don't want her to know. And so then you now have confidence, and that timestamp on, that most recent decision is in place, whereas in a paper world, that would just be really impossible to manage. It is impossible. Any other questions right now? One in the back. Oh, Jeff, hi.
Carol, Kathleen, thank you for the work that you're doing here. It's complex and it's vital. Kathleen, you peeled my eyelids back at dinner last night with your explanations of how some consent information can be transported in ADTs, and the fact that you had taken the DCH standard consent form legislated under Public Act 129 and put it into the standard specification system. And we have in the room someone who contributed to developing that form from its beginning from our HIT office, Phil Kordonowitz. And he's also co-chair of our privacy working group. We're going to really need you to get before that group and to go through the ramifications. But I was just wondering if you could summarize the ramifications in terms of what we can do through the patient choice project briefly, just at a high level.
Well, you could be one of the pilots. Right now they're accepting pilot applications. The VA has applied with a very similar use case to the one that could possibly be a use case for MiHIN, as has SAMHSA, and I think it is No More Clipboard. And I think there are several others that are lining up. If MiHIN were to sign up, one of the things you might want to consider that would be more fun than the usual pilot is to actually have a connect-a-thon on the FHIR consent architecture once we get past it getting into the ballot, and we have something that we're fairly sure is the one that is going to be commented on and start to move forward. So you could have a connect-a-thon. It's been done, ONC has done it several times for structured data capture and DAF, virtual. You could have it on-site or virtual. And given the international interest right now, I think you'd have a lot of participants. It would also give you a chance locally to put hands-on to working with FHIR, because typically in those connect-a-thons, they help beginners and they help the advanced people work through various tracks. So that's one of the ideas we've been thinking about.